Good day, faculty and participants. Welcome to the second day of the Virtual Interest Conference 2021. We hope you enjoyed the first day and ready for more exciting presentations today. A moment ago, we concluded the skills building section on grantspersonship for young investigators. We have excellent presentations on updates on treatment optimization using dolutegravir, HIV comorbidities, particularly cervical cancer, and novel approaches to manage patient retention. We will dedicate the second half of today to HIV in children and adolescents. We have presentations on elimination of HIV in children, diagnosing and managing treatment failure in children, and we are going to lace this with a lot of case studies. And then also we'll look at the role of dolutegravir in children. So this is the outline for today. I would like at this point hand over to Dr. Anna Laura Ross from Geneva and Professor Sam Phiri from Malawi, the plenary co-chairs for the next session. So I just hand over to them so that they can moderate the next session. Thank you.
I am Sam Phiri, Programs Director at Partners in Hope in Malawi. Partners in Hope is a local HIV care and treatment implementing partner supported by PEPFAR through USAID in Malawi. Welcome to the Interest 2021 virtual conference. This is session 2, HIV treatment optimization and comorbidities. I'll be chairing this session with Dr. Anna Laura Ross from World Health Organization. There will be 2 presentations in this session. I encourage you to put your questions on the chat. At the end of the 2 presentations, there will be a live discussion. The first presenter is Professor Francois Venter, who is a man not requiring introduction in this forum. Professor Venter is from the University of the Witwatersrand in Johannesburg, South Africa. Professor Venter.
Hi, everybody, and thanks for the invitation to speak. I'm a physician working in central Johannesburg, intimately involved in the introduction of dolutegravir into South Africa and Southern Africa, involved in clinical research studies as well as operational studies. And that raffia-looking thing is the chemical structure of dolutegravir. And that's what we're going to be talking about, is the rapid introduction of dolutegravir into programs and replacing efavirenz across large amounts of the globe in first line, second line, and third line antiretroviral therapy. These are my various disclosures, including being the PI on ADVANCE, one of the large studies done looking at the use of dolutegravir in first line therapy. So where are we here in 2021 as dolutegravir has advanced since 2018, 2019 WHO guidelines? Well, tenofovir does paroxysmal fumarate and occasionally TAF in a few countries such as Zambia and Botswana. Lamivudine and dolutegravir has pretty much become the standard first-line therapy in low and middle-income countries. In some countries, like in South Africa, about 20% of the patients are still on efavirenz-based regimens, but that's rapidly changing. The transition period is slowly while they're taking care of their stocks. But the future is TLD, that combination I just mentioned. And the variations of that actually in the rich world, where bictegravir is the preferred dolutegravir replacement and TAF is more favored over tenofovir. So the variation is actually remarkable that integrase inhibitor combination is what's been used across the globe. And because of the resistance barrier, there's actually almost no second-line therapy being experienced. The first-line failures are so few and far between that we're just not seeing second-line. I think we don't appreciate how little toxicity on first line we're seeing either. compared to the first-line toxicity we saw in the efavirenz-based regimen. So that even with tenofovir, the renal toxicity is far, far lower than what we predicted perhaps 10 years ago. There are cases of renal toxicity, but it's very, very low. And the dolutegravir toxicity, certainly the switches we're seeing are very, very small. And I've put there so far because we all thought D4T was this wonder drug until the toxicity actually declared itself. But we've got a fair amount of experience now with dolutegravir, and its toxicity profile is exceptional. In some ways, the resistance profile is also astonishing. As I said, there's almost no one that has failed dolutegravir because of resistance, and perhaps eventually we will fail it, and there have been these isolated instances. But so far, from a public health perspective, we've had no necessity for second-line failure. All we've had is the patients who have failed have required an intensified adherence intervention. And what we've also seen is a steady introduction of TLD into second and third-line regimens, where they've replaced those regimens in complicated ways. And with studies such as ARIA and ARTIST, we're becoming steadily more confident in the way that we're able to replace those, move patients on protease inhibitor-based regimens steadily in different ways onto these TLD-based regimens. So TLD is essentially taking over the world in one form or another. And steadily, these older regimens, these thymidine-based regimens, these regimens with protease inhibitors, these classes of drugs are steadily becoming more, more likely to become extinct. So this is a wonderful situation because our antiretroviral regimens are becoming simpler, and both from a supply line, but also from an understanding of toxicities line. And we've actually reduced the debate around first line, second line, third line regimens at the moment around whether we can get rid of tenofovir. Can we just go to 3TC and dolutegravir? And certainly in my part of the world, the issues are around, is can we get rid of tenofovir because we get the free added benefit of treating hepatitis B? And that's kind of the swirling debate that we have. So it's quite an embarrassment of riches that we're seeing in the antiretroviral world at the moment. So what's the lessons of dolutegravir? And the first lesson, I was thinking about how to structure this lesson. The first is, a new kid on the block may come. And I was thinking, a couple of years ago in 2012, I was sitting back when I was in the thick of introducing, we just won the debate around efavirenz, and we'd harmonized everything. And we were sitting back and appreciating the fact that finally we'd harmonized first-line therapy. And it was amazing that towards the end of the decade that we'd got tenofovir, lamivudine, efavirenz all together. And, we had finally, we made our peace with the fact that efavirenz is safe in pregnancy, that we had put rid of nevirapine, which is a living nightmare in terms of its complexity and its toxicity and the ethics of giving it to women. That it was great in TB, that we didn't have to have endless debates about dose escalation of efavirenz to 800 milligrams, that there were multiple fixed dose combinations, that it was relatively cheap, that we could move patients, and certainly in my part of the world, across borders where we didn't have to worry about changing formulations, and that we had evidence of moving it from, if patients did fail efavirenz, that we could move them across to PI-based regimens, and that transition was very, very highly effective. So that was a wonderful space to be. We found them wonder regimen, and then I remember having a conversation with the head of one of the heavyweights here at Aspen, one of the big generic companies in South Africa, and he sat me down and he said, hey, there's this new drug, dolutegravir. And I actually remember being mildly annoyed because I was like, we've put so much effort into efavirenz. Leave me alone. It's been so hard to get here. And we've fought so hard to get rid of D4T and to get onto tenofovir and to get these fixed dose combinations and to get the price down and to harmonize the regulations and everything. And he said, but it's cheaper. And I was like, yeah, but really, how much work it was to get you. And anyway, but at that stage, the cracks were starting to show in efavirenz, and the resistance barrier was poor, and we were starting to see the rise of NRTI resistance. We were starting to see breakthrough pregnancies in South Africa because there was this drug interaction with the hormonal contraception. And these nuisance side effects were stopping. They weren't just nuisances. They were real metabolic side effects. The CNS side effects were starting to affect adherence, and sometimes were actually really serious and even causing deaths. And so efavirenz actually was the weak link in all of this. So we started to look more and more at dolutegravir, and this drug started. So I think the first lesson is don't just think you'd found the perfect regimen, that in fact there were improvements coming along the line. The next lesson, and this is something I didn't quite appreciate until we started to dust off all the registration studies, that often the registration studies don't show you the real side effects. You have to really use these drugs at scale, and you have to use them in large cohorts and in the populations that you're going to use them in at scale. The registration studies sometimes, and the small observation studies sometimes exaggerate some side effects, and they don't pick up the real ones. And one of the things I was astonished to learn when I went back is that the D4T registration studies did not pick up lipoatrophy in any significant numbers. It was really the patients coming forward and complaining about it. The original Gilead studies of tenofovir, for instance, versus D4T didn't pick up much in the way of lipoatrophy, picked up the peripheral neuropathy. But it was patients coming forward and saying, hey, this stuff is really like messing with me, that picked it up. And the same with AZT. AZT, the bone marrow stuff was picked up, but not really the lipoatrophy, which was quite a late side effect. Tenofovir, everyone was very worried about the bone and the renal failure, but actually when we put it out in the field, the renal failure is actually is really unusual. And finally, with dolutegravir, all the stuff that we were really worried about, the iris and the drama around insomnia and the psychosis and hepatitis, when we put it out in the field, we saw very, very little of it. So I think what the big lesson here for me is when you're going to make major changes in programmatic stuff using drugs, anticipate that you're not going to get what you think you're going to get. And you do need to put pharmacovigilance front and center of what's coming up. And I think the weight gain that we saw with what we saw with antiretroviral therapy was something we did not anticipate. I'll get to that in a moment. You also need to you need to do the studies in the population that are going to get the drugs. And you don't treat women as just a side effect of as a population that you're vaguely going to study after the fact. And I think the neural tube defect signal was just something we still need to be angry about, is that if you are intending drugs to be used at scale, you need to design your studies and your registration studies with women in mind right from the get-go. And that means using these drugs in women who are going to become pregnant and studying the teratogenicity and studying the biokinetics, the pharmacokinetics and all of those stuff right from the beginning. And not treating women as an annoyance that you sort of do it in the phase 4 part of these things. You start looking at them. And I've watched WHO and all these other organizations starting to be much more proactive in terms of issuing guidelines. And I'm really proud of the people who've done that stuff, that have put JIS has put out journal articles starting to guide drug companies to start saying, this is how we expect new drugs to be looked at. And I think we are starting to see momentum around that. The other thing is that we now know that, sort of started doing the traditional thing, which is go and study these drugs in white middle-class gay men in the North, is not going to cut it anymore. And I think we're seeing increasingly people pointing fingers at international conferences and saying, hey, why are you not looking at populations that are actually affected by this? And looking at these articles which demonstrate that even if you just confine it to North America and Europe, these studies are not looking at representative population even within their own countries, let alone for the global HIV epidemic. And I think, again, these registration studies need to be more it just needs to be more representative. It's actually not that hard. And I think that there does seem, again, to be more movement in this area, and companies starting to at least on paper, commit themselves to doing that. And I think that we need to make our peace with the fact that TLD is actually so good that the next generation of better drugs are not likely to be oral, or they're likely to be oral drugs which are weekly or monthly, and likely to be injectable, implantable. And this TLD is so good, both in terms of its tolerability and side effect profile, as well as in terms of its resistance barrier, that it's difficult to imagine, unless some new side effect suddenly declares itself, that it's going to be improved upon. And these new injections and these new implantables are coming along. It's the route of administration that seems to be is going to be addressed, not the side effect profile. And I think that we need to understand that the rise of this is what's going to change things, and that in many ways, what this is going to pose is not around, the cost is one thing, but the biggest challenge around this stuff is the huge operational challenges this poses. That actually it's not a big benefit. I think people have just left that patients do want this. They want, and in many ways, I think patients have leapfrogged across clinicians in terms of wanting the stuff. But when patients come every 6 months to pick up their tablets and then realize they have to come 3 times in 6 months to come and get their injections to the clinic, that might actually be a significant impediment. And trying to find safe injection sites and places where they can get them, where cold chains potentially have to be maintained and where patients have to be registered, is an operational challenge we're going to have to think very carefully about going forward. My next lesson is obviously the thing I've been involved in, is that weight gain is inevitable. And I think this is a big lesson for all of us, is that it looks to me that I don't think the integrase inhibitors are implicated. I might be wrong, but I'm pretty certain that we're going to see weight gain on all modern antiretroviral, and significant weight gain, especially amongst Black women. And if this is the case, it has huge implications for drug development. And it means that we are going to have to start paying attention to lifestyle interventions right from the get-go when we initiate antiretroviral therapy, and not continually be worrying about which antiretroviral regimen is causing weight gain, anticipating that all of them are going to be associated with weight gain. I'll come back to that in a moment. And I think the last lesson is that the next breakthroughs may not be antiretrovirals, and that's I'll say this softly, is that with oral antiretrovirals, TLD might be as good as it gets, or that the tweaks are going to be very, very small. And the next thing is like, what do my patients need? And I think, I'll tell you what we're working on at the moment is we may need obesity drugs. We may need lifestyle interventions that are affordable and that are actually appropriate, that people can actually use in Africa. We may need proper diabetes care. We may need non-communicable diseases screening that's appropriate. And we need to keep an eye on the cure agenda. If something crops up that is difficult to do, that is very expensive, can we implement it? And this is the stuff that I think is going to be challenging us as HIV clinicians in the field going forward. It may not be the next tenofovir, the next replacement for D4T, the next replacement for efavirenz. It might be something that is actually a whole lot more complicated. And I think the next big thing is going to be the injectables. But after that, we really need to keep our eye on the ball that this is the next breakthrough that might come. So in conclusion, I think dolutegravir has really revolutionized things, but it's also sobered us that the next step is not, we're going to be splitting hairs around oral antiretroviral breakthroughs. That the other stuff is actually where we need to be focusing our energy and our creativity. The new era is the long-actings, but beyond that is going to be where are we going to site these long-actings? How are we going to make it happen? It's not as simple as just simply, putting the long-actings next to the orals in the clinic. And those breakthroughs, that obesity care in particular, I think is a huge challenge for us. Certainly in my clinic, we have nothing to offer our patients. Telling them to exercise and to go on to a healthy diet has done diddly squat for the weight gain that we're seeing within the clinic. So I think it's really exciting, and I think the challenges are coming thick and fast, and simply looking for the next new fancy drug is unfortunately not the easy win that we were hoping it was going to be. And I think for all of us, certainly those of us in Africa, we're going to have to look hard and look deep for those challenges that are coming. Thank you very much.
Thank you, Professor Venter. The second presenter is Dr. Lamek Chinula, who will be presenting about preventing cervical cancer among women living with HIV. Dr. Chinula is an assistant professor in the Department of Obstetrics and Gynecologist Division of Global Women's Health at the University of North Carolina in Chapel Hill. He is the clinical research site leader at the UNC project in Malawi. Dr. Chinula.
Thank you for the introduction. This is the title of my talk, and I'll focus on or give a brief description about cervical cancer prevention in Malawi as a case study. Cervical cancer is a leading cause of deaths among women, and the vast majority of these deaths actually occur in Sub-Saharan Africa, Melanesia, South America, and Southeast Asia. As you can see from this heat map of age standardized incidence of cervical cancer mortality, Cervical cancer is the most common human papilloma virus, HPV-associated cancer globally, and is an AIDS-defining illness among women living with HIV. As you can see from this map and this global map of HIV prevalence, the cervical cancer prevalence mirrors HIV prevalence globally, with regions that are hugely affected by HIV also bearing the most burden of cervical cancer. Cervical cancer is preventable with largely HPV vaccination and cervical cancer screening of eligible women. The World Health Organization provides a comprehensive approach to cervical cancer prevention and control. The schema on this slide provides programmatic interventions at different time points in the life cycle of cervical cancer development, from HPV infection with largely HPV vaccination for adolescent girls to cervical cancer screening for eligible women. In 2020, WHO Director General launched the global strategy to accelerate the elimination of cervical cancer by 2030. And it does include HPV vaccination for adolescent girls, cervical cancer screening with a high performance test, and that about 90% of women with a screening positive test or cervical lesion should be managed appropriately by 2030. So globally, how are we doing on HPV vaccination? This slide provides a global estimate of HPV vaccination coverage by region and income countries. Between 2006 and 2014, different countries have implemented HPV immunization program with approximately 118 million women targeted through these programs. However, as you can see, the vaccination coverage has remained low actually in populations, again, that are hugely affected by cervical cancer. To prevent cervical cancer, women can be screened using various tests to identify those who have or are at risk of cervical precancer. Conventional pap smear has traditionally been the screening method for cervical cancer. Effective pap smear screening programs have been shown to lead to substantial reduction in cervical cancer incidence in many developed countries. The same has not been possible in developing countries, which bears 80% of the global burden of cervical cancer. And this is because of the infrastructure requirements, training needs, and also the need for multiple visits for pap smear based screening. Over the past decades, efforts have been put in place to reduce the global cervical cancer burden through screening, and these are focused on development and evaluation of alternative screening tests to pap smear. These have included visual inspection with acetic acid. This provides several advantages. It is simple. It provides same-day result and allows for same-day treatment, especially when you use ablative procedures such as cryotherapy or thermoabrasion. However, VIA has the caveat that it has quality assurance issues and has inter-observer variations. HPV DNA testing offers several advantages because it actually evaluates for the presence of the virus, which is the primarily responsible for cervical cancer. There are other new methods that are still under investigations, such as DNA methylation and protein biomarkers, but I'll not go into further details about them. HPV DNA testing is a high-performance screening method with the highest impact. In a cluster randomized trial, which was implemented in India in a raw resource setting, they measured the effect of a single round of screening using HPV testing, pap smear, and VIA on the incidence of cervical cancer and also on the associated rates of deaths. What the authors showed was that a single round of HPV testing was associated with significant reduction in the number of advanced cervical cancer cases shown on this graph, compared to when you use HPV compared to when you use pap smear or VIA. They also showed that the same HPV testing achieved significant reductions in the number of cervical cancer deaths shown on this graph. However, there were no significant reductions in the number of advanced cancers or deaths in the group that had implemented cervical cytology, or the women that had been screened with VIA when you compare to control group. This map provides an overview of which countries are implementing VIA and HPV DNA testing. In brief, you will notice that most resource-limited countries, which are hugely burdened by cervical cancer, are implementing VIA, and high-income countries are the ones who are implementing HPV DNA testing. Quite recently, this year, WHO launched guidelines for cervical cancer screening with specific recommendations for women living with HIV. WHO now recommends HPV DNA testing in a screen, triage, and treat strategy starting from the age of 25 years among women living with HIV, with regular screening every 3 to 5 years. However, WHO further recommends that where HPV DNA testing is not yet operational, a screening interval of every 3 years when using VIA or pap smear should be implemented among the general population of women and women living with HIV. Again, once a decision has been made to treat for women who screen positive, WHO recommends that treatment should be provided as soon as possible within 6 months to avoid the risk of loss to follow-up. However, treatment can be deferred when women test positive during pregnancy. WHO further suggests that large loop excision of the transformation zone or cord knife conization for women from the general population and those living with HIV should be offered if they have histologically confirmed adenocarcinoma in situ. So coming to Malawi as an example, Malawi is one of the countries with one of the highest incidence and mortality rates from cervical cancer. It is estimated that 4,000 women diagnosed cervical cancer per year, and that was in 2020, which was an increase from 3,600 women. And the number of deaths has also been increasing over the years. Malawi also has a high HIV prevalence, with 9% of the adults between 15 to 49 years being HIV infected. The HIV prevalence is actually higher among women compared to men. Malawi also has one of the vibrant antiretroviral treatment program, and this has provided a nice platform for increasing access to cervical cancer screening among women living with HIV. And this has been possible through integration of cervical cancer screening into HIV care clinics. How about the HPV vaccination? Malawi did pilot an HPV vaccination program in 2013. It was a school-based demonstration project. And following the experiences where about 80% coverage was achieved in 2 districts, Malawi launched a national HPV vaccination program for adolescent girls. It targets 9-year-olds. It's a facility-based program, but it has a component of school-based on a quarterly basis, depending on the school calendar and also availability of resources. In terms of cervical cancer screening, Malawi has been implementing a VIA-based cervical cancer screening with ablative treatment with cryotherapy and thermoabrasion. Over the years, we've seen an increase in the number of facilities providing screening and also treatment for cervical cancer. And on the right graph, you will see trends in the cervical cancer screening for the Malawi National Screening Program. You'll notice an increase in the number of women screened every year from 2011 all the way to 2020. This graph shows the screening coverage, which has been increasing, and then we saw a drop between 2016 and 2017, but this is actually attributed to the change in the target of women who were being screened prior to 2017 and after 2017. After 2017, 25 to 49-year-old women are being targeted for, whereas before it was women 30 to 49 years. Again, the target for population screening coverage was 80%, but from 2017, the target was dropped down to 70% to align it with the WHO goal for 2030 cervical cancer elimination strategy. So this explains this change. However, we've been seeing an increase in the coverage rate over the past years. And a lot of this has been largely because of the support from PEPFAR and Global Fund for HIV and AIDS care that has been used to actually scale up cervical cancer screening among women living with HIV. One of the challenges that the program has faced is that women who screen positive have not been adequately treated. So on this table, you will see VIA positive women. The rates have been ranging from 4% to somewhere like 7%. But those who have been treated, especially prior to 2017, less than half of those who screened positive were getting treatment. This changed with the introduction of thermoabrasion, which actually allowed for more women to be treated to the point that between 2017 and 2019, we actually saw a rise in the number of women being treated when they screen positive. Another interesting group is the women who screen to be cancer suspect. There's been poor linkage to care about of women who are cancer suspect at screening. However, the efforts, several efforts are being put in place to actually improve or address this challenge. In conclusion, we've seen that cervical cancer burden is disproportionately borne by countries with a huge burden of HIV. The rapid rollout of the vaccine, the HPV vaccine, especially in resource-limited settings, might be the only feasible way to actually bridge the inequalities in cervical cancer burden and prevention. And this does require government commitment and advocacy. There's also need to rapidly roll out HPV-based screening and improve the linkage to care of those women who screen are positive. However, we need to build on successes of what we've previously implemented in cervical cancer screening, including lessons learned from VIA-based screening. There's also need for context-specific strategies to ensure that women who screen positive are actually linked to care. Another aspect that I didn't touch much is the issue of treatment failure among women living with HIV, which is very, very pertinent and an area that needs to be researched adequately. I would like to acknowledge the Malawi Ministry of Health Reproductive Health Directorate and also the organizing committee of the Interest Conference. This marks the end of my presentation. Thank you.